Bonked the head, knocked the noggin, got the bell rung. This happens all day, every day to all of us. Children especially, with their disproportionately large heads and developing coordination. Sometimes it can be serious, but often it's not. How do we best deal with this very common presentation? Minor blunt head trauma.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. You've seen this many times, and you'll see it again. The well-appearing youngster with very worried parents after blunt head trauma. We can fall down ourselves in a few domains: risk assessment, decision-making, and communication. Let's talk about best practices in helping children and families in the ED. First, a little background. Traumatic brain injury is a leading cause of death and disability in the United States, affecting children disproportionately. Nearly 500,000 emergency department visits for head trauma are made annually by children 0 to 14 years of age. Well, what's the big deal? Just spin them down, light them up, and get the scan, right? We don't have empiric data on the effects of radiation. It's all extrapolated. But our best current understanding is that lethal cancer rates from a single CT of the head may be as high as 1 in 5,000 for older children and 1 in 1,500 for infants aged 1 year and younger. So, in deciding whether or not to obtain a CT scan in the child with minor blunt head trauma, we have a decision to make. We have to weigh the immediate risk of missing a clinically important traumatic brain injury against the long-term risk of exposure to ionizing radiation. It doesn't help that parents today seem polarized on the subject. The majority want everything done. That is, they believe a test more than our clinical judgment. Or just the opposite. They're actually hyper-aware of the ionizing radiation involved and refuse a scan, which can pose quite a bit of difficulty if the scan is needed. So we're left with a tangled web of clinical findings, public awareness of the consequences of traumatic brain injury, parental expectations and preferences about CT use, our own risk tolerance, and the present medical legal climate. Several investigators have reported clinical prediction rules for imaging in pediatric minor head trauma in large observational studies with varying designs, different subject cohorts, and decision rule performance. Some of these have been multi-center in design and have included thousands of children with minor head trauma. The inherent tension in these studies lies between the need to identify a clinically important traumatic brain injury and the desire to avoid unnecessary CT imaging. Figuring out what defines a clinically important injury is challenging. All would agree that identifying children who require neurosurgery is essential. Other children may not need neurosurgical intervention, but require intensive monitoring of the traumatic brain injury as an inpatient. Still others may develop post-concussive syndrome and will need ongoing evaluation and outpatient therapy. Enter the PCarne Study. The Pediatric Emergency Care and Research Network enrolled 42,412 children younger than 18 years of age with head trauma and GCS scores of 14 to 15 in 25 North American emergency departments. The investigators found that the absence of certain clinical features corresponds to very high negative predictive values for clinically important traumatic brain injury. There were 2 validation sets, one for children less than 2 years of age and one for those 2 and older. For children aged 2 years and younger, the negative predictive value for clinically important traumatic brain injury was 100%, with 95% confidence intervals, 99.7 to 100%. For those children aged 2 to 18 years, the negative predictive value was 99.95%, with confidence intervals 99.81 to 99.99. That is, the absence of 6 clinical features in each of the age groups makes the likelihood of a clinically important traumatic brain injury very low. These patients typically don't need a CT, as the risk of finding something clinically important is similar to or lower than the risk of inducing a lethal malignancy from the CT itself. Now, on the flip side, this doesn't mean that children who don't meet all of the PECARN low-risk predictors need a CT scan. For example, some risk factors in isolation are associated with less than 1% risk of clinically important traumatic brain injury. For example, isolated history of loss of consciousness, isolated history of vomiting, isolated severe mechanisms of injury, and in infants and toddlers younger than 2 years of age, isolated scalp hematomas. Many of these children with only one PECARN risk factor can be observed for resolution of symptoms rather than undergo CT scanning. However, children with a GCS that remains below 15, or those who have other signs of altered mental status, or those with physical signs of skull fracture should typically undergo CT scanning. Okay, blah 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 statistics and blah-de-blah epidemiology. How can we use this at the bedside? Some things are best left to be looked up, but some things we just have to know. What's the dose of rocuronium for RSI? Fentanyl for pain? Midazolam for seizure? The same goes for assessing risk for blunt head trauma, and I'll tell you why. You've heard this phrase before. Medicine is show business for ugly people. Whether you're hot or not, a lot of what we do is managing perceptions. It's modern-day magic. When we walk into the room to evaluate a child with head trauma, there is a lot of fear, anger, shame, and apprehension in the room. We have to tame those beasts. On the spot, we have to know why we're making our decision and counseling our parents, because the decision to scan is based on clinical factors that are right in front of you. You're basing your decision and recommendations on the spot. How confident you are and how clear you are and how you can explain what is going on will make or break the parents' trust in you and will heavily determine their adherence to the plan. If you scurry away with a lack of confidence saying, "I'll be right back," only to return after a Google search, and now you're miraculously confident again, the parents are not going to buy it. This will result in one of 2 scenarios. Either you argue, you cave and do something that you didn't really want to do, or something that's not in the best interest of the child, or they leave upset, determined to get answers, and they show up to another ED now armed with hours worth of rage, and our poor brother or sister in arms gets to deal with that. And that child may not get what he needs. We have to know at the point of care, at the point of contact, why we're making that decision so that all will go smoothly. You saw this coming. A mnemonic. Actually, 2 of them. one for the less than 2-year crowd and one for the crowd that's 2 and older. First, for infants and toddlers less than 2 years of age. You think, what's the most obvious finding? Maybe a scalp hematoma. So, the mnemonic is scalps. S. Scalp hematoma. C. Caregiver concern. A. Altered mental status. L. Loss of consciousness greater than 5 seconds. P. Palpable skull fracture. And S. Severe mechanism, defined as a fall of greater than 3 feet or a high-velocity mechanism. After a regression analysis and study on a validation cohort, these characteristics were the most important in support of a child who doesn't need imaging. That is, if you have none of these characteristics and you were not very worried in the first place, you're in pretty good shape. Now, a few things to be careful with. Be careful with the child who's less than 3 months of age. Don't use PECARN if you're worried about non-accidental trauma. It would be ludicrous to try to use these for a hemophiliac. My point here is this. These are decision tools, not decision rules. They serve to support your decision. If you didn't want to scan the child in the first place and PECARN supports you, you're in even better shape. If the circumstances were such that you are concerned about this child, and I can't be there with you for every case, PECARN certainly didn't study every conceivable situation. Do what you know to be right. Just don't feel obligated to scan if the child is not 100% PECARN negative. It's just not a thing. So, to review, for the less than 2-year crowd, use scalps. S. Scalp hematoma. C. Caregiver concern or change in behavior. A. Altered mental status. L. Loss of consciousness greater than 5 seconds. P. Palpable skull fracture. And S. Severe mechanism. Children 2 years of age and older, they present differently. They're verbal now. Their mechanism of injury is likely different. For them, we need to think basilar. B. Basilar skull fracture signs. Think raccoon's eyes or battle sign. A. Altered mental status. S. Severe headache. I. Injury mechanism severe. Okay, I cheated a little bit in the making of this mnemonic, but bear with me. This is similar to the other age group, except you have a fall of greater than 5 feet, as well as the high velocity object. L. Loss of consciousness. The little a is silent, and we have R. Regurgitation, recurrent vomiting. So that's basilar. Basilar skull fracture, altered mental status, severe headache, injury mechanism severe, loss of consciousness greater than 5 seconds, a little a in the middle, and regurgitation. The case of the toppled toddler. A young mother brings her 5-year-old daughter to your ED for sore throat and fever. It's a busy day, and the waiting room is getting crowded. While her mother signs her in, the girl begins chasing her younger brother down the hall. The 21-month-old boy, new to this environment, climbs up a chair and falls to the floor 2 feet below, sustaining a frontal hematoma. He cries immediately and is comforted by his mother and now tearful sister. Now both of them are in your exam room, and the little boy is dutifully playing with his toy truck. Anticipating his mother's concerns, you remember the SCALPS mnemonic: scalp hematoma, caregiver concern, altered level of consciousness, palpable skull fracture, severe mechanism of injury. This is for the child younger than 2 years of age. His scalp hematoma is frontal, and the rest of his exam is normal. His behavior is normal. He's not altered. He didn't lose consciousness. He has no palpable skull fracture, and he did not have a severe mechanism of injury. So after attending to his older sister's needs, you explain to the boy's mother that with no findings in the age-appropriate PECARN prediction rule, her son is at very low risk for clinically important traumatic brain injury. The only intervention indicated at this time is an empathetic review of child safety. You feel confident that the evidence backs your decision, and the mother is reassured by your thoroughness and confidence in the explanation. The case of the slippery sibling. A 2-month-old girl's grandmother brings her to you for not eating anything since last night and just not acting right. The child's mother is at work, and the grandmother who is visiting has scant information about how the child's been doing. On further questioning, there was a family get-together last night, and multiple relatives took turns holding the new baby. The grandmother does recall the child's having slipped from the arms of a standing relative onto a carpeted floor. Her grandmother was not overly concerned at the time because the baby didn't seem to cry much afterward. On exam, you see a 10-week-old infant who is sleepy but awakens and tracks well. There's no evidence of scalp hematoma, and a head-to-toe exam shows no other evidence of trauma. The grandmother is eager to get something for her stomach so that she'll eat better. The infant appears relatively well now. Nonetheless, she presents with more than one of the clinical factors in the age-appropriate PECARN prediction rule. The most striking is her change in behavior, noted by the grandmother and exhibited by decreased intake by mouth. The history of not crying much when she was dropped opens the additional question of a loss of consciousness at the time. Although each of these findings could be explained away individually, this case highlights the motivation of most clinical prediction rules: to be assistive, not directive. That is, your initial inclination is to image this young infant in the face of an incomplete history and a few non-reassuring findings. You get a non-contrast CT of the head, and it reveals a subdural hematoma. The girl is admitted for observation, and her inpatient course is uncomplicated. An investigation for non-accidental trauma is unrevealing, and on a 2-week follow-up, the girl and her family are doing very well. You're glad you listened to your gut. The case of the falling 4-year-old. It's later in the day, and the department is getting busier. A mother brings in her 4-year-old son for ear pain that began this morning. He has no fever or other upper respiratory symptoms. He also complains of a strong headache, which his mother first noticed when she found him in his room crying. He was playing with his older brother in their room where they share a bunk bed. The boy's mother was busy cleaning the house, didn't hear any commotion, and he and his brother seem very shy when asked if anything happened today. On exam, you see a tired, cranky, but interactive 4-year-old with mild tenderness to palpation to the back of his head. He has bruising behind his right ear and a full tympanic membrane slightly bulging with dark fluid. the basilar mnemonic, basilar skull fracture, altered level consciousness, severe headache, severe injury mechanism, loss of consciousness, regurgitation. This is the one that comes to mind for children aged 2 years and older. You assume that his ecchymosis is a battle sign. He has a rather severe, unrelenting headache and probably what is a hemotympanum. All of this probably happened from falling off his bunk bed. So that gives you a severe mechanism of injury for a fall greater than 5 feet. All of this puts him at risk for a clinically important traumatic brain injury. With 3 of the basilar criteria, the B, the S, and the I, you get a CT. It shows a mildly depressed temporal bone fracture without parenchymal bleed. He's admitted, and his hospital course is complicated by a brief, generalized clonic seizure. He's discharged with a short course of prophylactic antiepileptics and does well with a 1-week checkup and is taken off his medication with his 2-week neurosurgery follow-up. The case of the passed out player. A 13-year-old boy and his mother come to see you just to be sure. Just to be sure what happened. Yesterday afternoon, he was at his first practice for tackle football, and wanting to impress his friends and coach, he lunged at his opponent and face-planted on the ground. The boy says his teammates told him that he was out like a light for a few minutes. The boy then recovered and resumed play. Mother just found out about this 30 minutes prior to coming to the emergency department. The boy had a slight headache last night, but states that he feels fine today. He casually mentioned the episode for the first time to his mother this morning, and she promptly brought him in to see you today just to make sure everything's all right. He denies headache or vomiting. He has a normal exam. The injury occurred less than 24 hours previously, making the PECARN prediction rules still applicable. You remember your basilar mnemonic and note that his only finding is a history of loss of consciousness. Really, an isolated history of loss of consciousness, since he has no other findings suggestive of TBI. Today, you're unconvinced of his potential risk for a clinically important TBI, and remember that well-appearing patients with certain isolated PECARN prediction rule findings may be observed initially. This boy essentially has spent his observation time at home. His mother is hesitant about this course of action and feels more comfortable if a test were ordered. Since his injury occurred almost 24 hours before seeing you, you can tell the mother confidently that an observation period was initially warranted, and fortunately he fared well and no further immediate intervention is necessary. You talk about concussion precautionary advice, and you feel satisfied that you were able to avoid unnecessary radiation in your patient. With PECARN in your back pocket, you just sailed right through each of these cases. Good job. We've talked about our own assessment and our own logic in decision making, but what about communicating that with parents? All of the wonderful thoughts and evaluation that you've made won't make a lick of difference if we can't get mom and dad on the same page. The current litigious medical legal climate and our fast-paced culture of expecting all information and resolution to a problem quickly and right now can cause a strain on the discussion with parents about diagnostic imaging. The prevalence of CT imaging in U.S. emergency departments has more than doubled in the past decade without a significant increase in the prevalence of life-threatening conditions. In fact, some experts point to a contributing factor of parental expectation of a rapid diagnosis without understanding the potential risks. Understanding and validating parents' concerns and fears may be the best entry to that discussion. Most parents go to physicians in search of more information and advice. Many are exposed to internet resources of varying degrees of quality. If we have a brief, frank, compassionate discussion of the risk-to-benefit ratio for their child, this can help to maintain that therapeutic alliance. To this point, a survey was taken of parents before and after reading an informational brochure about radiation risk from imaging. Before reading the brochure, only 66% of parents understood that CT involves radiation. After reading the brochure, 99% of them understood this. Before reading, only 13% believed that CT increases lifetime risk of cancer. After reading, 86% understood the risk. Although this is difficult to do, it's hard to take the time to talk to people. A few moments of a frank but understanding and compassionate discussion can really be the only treatment that's needed. Observation of the child with certain clinical features is a viable strategy to monitor the injured child's status, give you a little time to gain an opportunity to educate and counsel the parents further, and potentially to reduce unnecessary radiation exposure. One study's sub-analysis found that initial observation for resolution or worsening of symptoms and signs significantly reduced the rate of CT imaging. Regardless of the conversation, parents will respond well to the physician who puts the child's best interests first. So sometimes that's avoiding radiation when appropriate, and sometimes that's trying to convince them to get the scan. The proliferation of the use of CT imaging over the past decade has led to a multidisciplinary national awareness campaign called Image Gently. The approach is multifaceted: public awareness, provider education, and institutional guidelines to implement CT scanner protocols that use less radiation in children. The overall message is the concept of radiation exposure known as ALARA, as low as reasonably achievable. The Image Gently campaign produces patient and provider educational materials as well as a medical imaging record, similar to an immunization card. All of these are in the show notes. In summary, we all know when a scan is really needed. Assessing risk in a seemingly well child can be tricky, and communicating that risk with parents can be even trickier. Remember your bedside buddies, scalps and basilar. For under 2, scalps: scalp hematoma, caregiver concern, altered mental status, loss of consciousness greater than 5 seconds, palpable skull fracture, and severe mechanism. For children 2 years of age and up, basilar: basilar skull fracture, altered mental status, severe headache, injury mechanism severe, LOC more than 5 seconds, a little a, and regurgitation. Remember, these are tools, not rules. They should support and be in sync with your gestalt. If not, spend some time thinking, talking, examining, and re-examining. And if you got to scan, you got to scan. Do what you need to keep the child safe. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.